Dr. Bertelsman with Chiro Up, and I wanted to show you my take on a presentation that came in this morning. Kathy came in this morning. She has had some lower back pain for the past month or so, radiating from her back into her buttock, and then this weekend bent forward to pick up her granddaughter and had pain that started to shoot down into her leg, down into the right leg, about down toward the knee. Got a lot worse this morning when she put her foot up onto a tub to put some lotion onto her leg, and it became almost intolerable. She'd rated it a 10 on a 0 to 10 scale. Right now she's uncomfortable because she told me she doesn't like to sit. She'd rather be standing. She says that when she lifts something, bends, twists, or sits for any period of time, the pain intensifies. She feels a little bit better when she's able to stand. Walking is uncomfortable, and you describe it as an intense, dull discomfort. So our first, and there's no other neurologic signs or symptoms that we can see. So our first goal is to define, well, what's causing this terrible pain? And we have some suspicions from the history, and one of my suspicions was disc. So one of the tests that we did was a slump test, where, Kathy, if I can have you bring out your right leg, and does that cause any pain?
Mm-hmm.
Bring out your left leg, does that cause any pain?
Yes.
And now bring out both legs, and now lean forward, and is that painful?
Yes.
Okay. So she really didn't need to answer that. We can see the grimace. That slump test causes a lot of pain, really, on both sides. When I expanded this then straight leg was positive at about 40 degrees for radicular discomfort on the right side. Well leg raise was positive, which now gives us a very high indication of there being a disc that's present. We have a positive Valsalva, positive Soto Hall, so we can be pretty confident that there's disc involvement. I wanted to make sure there was no neurologic involvement, reflexes and strength, even repeated strength testing of the lower extremity as far as heel or toe walking. That's all good. There's no finding there. So our next question is, do we need imaging? This is a relatively new onset. There's no findings that are radiating, no neurologic beyond the knee. There's no neurologic deficits along the way, no red flags. And so we say we're not going to take any plain film, and obviously advanced imaging would be reserved if we fail treatment or if we see that there are neurologic deficits that have been progressive or any red flags. So certainly don't meet those criteria. So we have a structural diagnosis that we can be pretty certain that this is a lumbar disc lesion. Now what I need to answer is, what do we do to effectively manage this? And what we know is that with any back pain, regardless of the structural diagnosis, if we can classify it into one of 5 categories, we can choose our treatment. We notice that some patients respond to knee to chest exercises, and some to extension exercises. Some like manipulation, others don't. Some like lumbar traction, and others don't. And some like to be given exercise programs. And so we don't want to guess at what's going to work best for Kathy. Her pain's at a 10. It needs to be solved right away. So we're going to classify that and determine which treatment is most effective. So we're going to look, number one, is it manipulation? When we did motion palpation, there was definitely restriction down at the base of the spine. There's a lot of muscle tightness in the area. The pain is relatively recent, and she has no limitation in rotation of the hip. So the Fritz criteria say that manipulation is probably appropriate. There's not a contraindication. Now the next category is, she flexion biased, meaning does she like flexion? No, she hates flexion because she doesn't like sitting. I know that she's uncomfortable right now. She doesn't like to be in a car. She hurt herself picking somebody up in flexion. She hurt herself this morning in flexion. We know she's not flexion biased, so we're not going to give her knee to chest exercises or flexion protocols. Is she extension biased? Absolutely. She loves to be in extension. She likes to stand up. She likes to do repetitive extension exercises. When we classified that, we see that reduced the back pain as well. And does she like traction? Well, we might need an MRI or an X-ray at least to tell us, is there advanced degeneration, or is there a lumbar disc lesion that might be responsive to traction? But for now, we're going to assume that we're going to get great results with the extension biased, and if we need to incorporate traction later, we will. And the 5th category is she unstable? Is there segmental instability? So when I do the PA shear test, there's discomfort. That can mean the joint's either too mobile or not mobile enough. But when I have her lift her legs to stabilize that, the pain does not change, so it tells us that it's probably not instability. We're also not dealing with a patient who's under 40, hypermobile, and would be a classic instability patient. So our categorization of Kathy is that she has a lumbar disc lesion structurally. She has the classification that we're going to treat in extension and manipulation. So let's go with the treatment for what we're going to do for the extension biased patient who likes extension. Kathy, if I could have you lie face down on the table. Very good. And you're fairly comfortable lying on your stomach.
Yes.
Does your pain change lying on your stomach?
No.
Not appreciably. So now, Kathy, could I have you prop yourself up on your elbows, just a kind of a sphinx position? What happens there? Does your pain get better or worse?
Seems to be a bit better.
And then come back up again and keep going. What's happening?
That seems to be better.
Better. Okay, and back down again and up again. Less into your leg.
I believe so, yes.
Good. And let's do 10 of those. And what's happening to your leg pain?
It's not intense or anything. I can just feel it pulling a
You
bit.
feel an awareness in
Yes.
your buttock and leg? Okay.
Definitely.
Let's do 3 more. Okay. And again. Not getting worse?
No.
Okay. And then back down again. Good. And then I'm going to. Okay. So we know that the patient is extension biased, and that extension is going to decrease those symptoms. We're going to prescribe extension biased care here, as well as home exercises. Make sure that they're using a lumbar support cushion anytime that they're sitting in a car. We're also going to give that patient repetitive extension exercises to perform hourly throughout the day. We're going to give them instructions to imagine that they're duct taped to a fluorescent light tube between their head and hips, and don't break that tube. Keep it nice and stable, and we should see a great response in a short period of time. I'll keep you updated. Thanks.
Hi, I'm Kathy from a couple weeks ago, and just to give you an update on the progress that I've made is I'm being very cautious on how I bend over and not bending and twisting, give my back time to heal, and my knee. I make sure I never wear shoes without some type of arch support in them. I don't go barefoot. I do my extensions at home, trying to keep that up to date and build that strength back up in my back. And plus coming to Dr. B and getting my treatment. And I think I'm probably about 70 to 75% better than I was when I initially came in. So everything's going the way it should.